Hello, my name is Dr. Dan Reidenberg. I am the Executive Director of SAVE, Suicide Awareness Voices of Education. We are the U.S. leading national nonprofit NGO organization working to prevent suicide through public awareness and education, training, and to reduce stigma around suicide and mental health, and to serve as a resource for those that are impacted by suicide in our country. SAVE has been in existence for more than 30 years. We have volunteers and charters across the United States of individuals working on suicide prevention, all based out of our headquarters in Minneapolis, Minnesota, in the United States. I'm the executive director of SAVE. Our website is save.org. That's SAVE.org. I also am the managing director of the National Council for Suicide Prevention. The National Council for Suicide Prevention is a collaborative of the 7 national leading suicide prevention organizations in the United States. Each of these organizations functions in a bit different efforts. Some focus on college campuses, some focus on high schools, some focus on research, some focus on training. But collectively, all have suicide prevention as a main focus of their mission of their NGO in the United States. I'm also the General Secretary for the International Association for Suicide Prevention. I am pleased to be here to speak with you about the U.S. COVID response, which has been broad and fragmented at the same time. In the United States, we have data, but it is not current data. We do not have real-time data capturing suicide as we do for COVID response. What that means is that we have and continue to lag behind around knowing the actual suicide numbers. The Centers for Disease Control and Prevention out of Atlanta, Georgia, which is the surveillance organization for the federal government, releases suicide data about 2 to 3 years after the year ending. So the current data that we have is for 2018, long before COVID hit. So we don't have any current data on suicide in the United States. However, we do have quite a bit of anecdotal information that suicide has actually decreased in the United States during COVID, during this year of 2020. States, local governments, and counties have reported to various state agencies a decrease in suicide. This has been across all ages as well. Now, again, this is preliminary data. It's anecdotal data. It isn't collaborative data that is put together by the CDC to represent nationally. But what I've heard pretty uniformly across the United States is that there has been a decrease in suicide. However, we also have some data that indicates that distress for the citizens, the public in this country, is increased, and quite significantly. The CDC and others have done surveys, national surveys, and what they have found is about a 40% behavioral health increase in distress, a 30% increase in anxiety and depression, and about 11%, 1 in 10, reporting having serious thoughts of suicide during the pandemic. This is an increase, and this is significant and something that we need to pay attention to as the virus continues to impact all of us in the United States and around the world. The longer this distress goes on, the more concerned that I and others are that suicides will begin to increase. We have some anecdotal reporting that there has been an increase in suicide attempts, and particularly for young people. This is not, again, corroborated. This is anecdotal information, and it is not generalized or consistent information across the country. But we have some hospitals reporting in a couple pockets in the United States increases in suicide attempts, in particular for young people. There is some reports from the CDC about increases in suicidal ideation among young people, although it was a very small sample size of about 700 people, and of that, about 100, just over 100, reported increases in thoughts of suicide, and that was among the 18 to 24-year-old age range. So that adolescent period, we don't have good information on at this point in time. So this is troubling because we have reports of distress. We have reports of increased anxiety and depression. We have some reports of increase in substance abuse. About 13% have reported increase in substance use, whether it's alcohol or other drugs. And with the opioid crisis that is impacting the United States, these are very concerning numbers during this very difficult time. And again, while the actual numbers of deaths have likely gone down, the longer this pandemic goes on, the more likely it is that those numbers are going to increase. So the question then becomes, what has been the U.S. response relative to this crisis? And while there have been a number of things that have been done that are very positive and we hope continue, there's much more that needs to be done. Let me start by talking about the promotion of the U.S. National Disaster Distress Helpline. This is a crisis phone line that anybody can call 24 hours a day, 7 days a week for free if they're in distress. This is a separate and distinct phone line from the National Suicide Prevention Lifeline. Both are in existence, both are free and available to the public, both are anonymous sources of support. While there has not been a general large or steady increase around the National Lifeline for suicide prevention, there has been about an 800% increase in the use of the distress helpline. That is concerning to us. Another major advancement in the U.S. response to the COVID crisis around mental health, it's true around physical health as well, but specifically to mental health, has been the federal government allowing the use of telehealth for providers to care for their patients. This is a significant increase and never been done before. So now mental health and chemical health providers can provide these services much like this virtually. They can provide it by telephone or video relay to anyone that there's a patient of theirs, and it can cross state lines in the country. Those two advances were policy advancements that have made a very positive impact in reaching people who are not able to access care during this time. Much of that is because providers are not seeing patients directly, so they're seeing them virtually. Another advancement that the federal government made was around reimbursement, payment for the services for mental health and chemical health services that are done by providers that are done virtually. This is something that has never been done before here in the United States, but is also helping quite a bit to be able to provide access to care for those who need it most. So those major advancements are things that we actually hope as become policies that maintain beyond COVID. But we know this because we know that a majority of Americans do not seek care for mental health or chemical health. And yet this change in legislation has provided better access, much more quick access, and reimbursement for those services. Now, I want to mention a couple other major initiatives that have taken place. In the United States, there is a public-private partnership that is comprised of both members from the general public. Those are various departments and organizations within the United States government. For example, the Department of Defense, Homeland Security, Transportation, Public Safety, all the various departments within our federal government, and then private groups. These are local and state and national organizations that come together to have a unified voice around suicide prevention. This National Action Alliance for Suicide Prevention has been in existence for 10 years. And in response to COVID, they created a special task force to address the issues around the COVID crisis. They brought together two leading voices in the United States, former Senator Patrick Kennedy, someone who has lived experience with chemical health and mental health issues, as well as Dr. Josh Gordon, who is the director of the National Institute of Mental Health. Again, you see a replication of the model of a public-private partnership here, even formed within this COVID response task force. This task force is looking at some very specific efforts to help during the crisis. One is around unified messaging and consistent messaging that takes place throughout the country and throughout all organizations, messaging and talking about, communicating about the crisis. The second is around crisis care, what kinds of crisis care are available, where those services can be made available, how they're accessible, and suicide-related care. Early on in the pandemic, in the spring and into early summer, there was a situation whereby people were afraid to reach out to local hospitals when they were in a suicide or a mental health crisis. They did not believe that they would get admission to a hospital because the hospital was a COVID facility, or that they wouldn't allow a behavioral health patient in. This became very distressing messaging that went out even through public media, which left patients in crisis at home. So one of the areas that this task force is working on is suicide-related crises. Where can people go if, in fact, a hospital is a COVID-designated hospital, versus what units are available and what other services are available for prevention of a suicide-related crisis. The task force is also looking at policy issues. Again, I mentioned a couple of those around the telehealth and reimbursement. They're going to look at other broad policy initiatives that can carry on beyond COVID. Another important aspect of this task force is looking at is there a way for the United States to get real-time data much more closely in line with the kinds of data we get for other diseases and public health issues. This would be very beneficial because we know research tells us that if, for example, we knew there was a suicide in an area or potentially multiple suicides, a cluster of suicides, if we could get that data real time and get information to that community on prevention efforts and postvention efforts, we could prevent other suicides from occurring. So this task force is going to be looking at where and how real-time data could be obtained. A subgroup of this task force is going to be looking at suicide among special populations, not just veterans, but in particular African Americans and Native Americans, American Indians, and Alaska Natives throughout this country. The American Indians culturally have a suicide rate double that of Caucasian Americans. So this task force is going to be looking at some of these specific special areas. That has been largely the federal response. It has been to find access to services quickly and figure out how to pay for them, and to make sure that people know where to go for them. Again, that disaster stress line. And then this development of this task force that's going to look at some of the broader issues. At the same time as these things have taken place, there have been a number of national, regional, local, and community and other NGO initiatives that have taken place during this COVID period in 2020. Many national NGOs have created resources that have been widely disseminated to the public throughout the crisis. These have been around stress and self-care, wellness and resiliency, communication, taking care of children and youth who are anxious and depressed during the pandemic. In the United States, we've had much controversy around school and whether or not youth would be returning to school, or young people going to college would be returning to college. There have been a number of resources that have been developed by many organizations trying to assist people in having these kinds of conversations. Likewise, these organizations and some national organizations have worked to help develop policies for schools as well as for universities, helping them navigate returning students. The third is around workplaces. Some organizations have been assisting workplaces in developing policies for when employees would be returning to work during a crisis, and how to help manage distress of employees when they're not at work. So that has been another major national initiative that has taken place by some of the organizations across the country. Most of these resources have been very targeted. We have resources that have been developed for children, for young adolescents, for middle-aged adolescents, for young adults, for adults, and for seniors across the country, because we see suicide as a lifespan issue in this country, and we know that it hits every age group. So many of the resources that have been developed really target all of those populations. Each one of the federal departments has also that works in suicide prevention has also developed materials and resources that are available online for the public. These are considered credible resources. So, for example, the National Institute of Mental Health has developed information specific to COVID response, giving information on what data is known generally about suicide, what data has come from the polls that I mentioned earlier, what risk factors are increased during COVID, what warning signs to pay attention to. The Substance Abuse and Mental Health Services Administration, which is another branch of the U.S. federal government under the Department of Health, has developed a grant program to very quickly release $40 million to a number of organizations working in COVID response. They have also put out a number of one-page documents for families and for providers of healthcare on dealing with COVID response. The Centers for Disease Control has put out information as well. So as we can see, there's been much information put out from a national standpoint, both from federal partners and from private partners and local community organizations. Another area that has made some significant changes around media and social media. Social media companies have developed a number of resources for individuals on their platforms. Facebook has really led that effort, developing resources for people and a COVID response plan on their website, on their platform. Others have done the same thing. Other search engines have provided information on COVID response, so people have easy access to information. And all of these social media companies have been very responsive to trying to provide resources and connection to for example, where testing might be available, where providers are, hospitals are, where doctors are available to people. So those technology companies have also responded to this crisis, and they have worked with myself and others in this country and around the world to collect that data and information and input it into their systems and their platforms so people have good access to that. And they have actually changed over the period of months the kinds of information they're putting out as the crisis continues. So, for example, when testing is more available in an area, they're able to update their system on that. The traditional media, the news media, has also been responsive during the COVID crisis. There has been quite a bit of reporting around the mental health of American citizens and polls and surveys that have come out indicating increased distress. And the media has reported on that, as well as the disaster helpline and the National Suicide Lifeline as resources for people to turn to in cases of crisis. That has been very positive. Earlier this year in the spring, I, along with the International Association for Suicide Prevention, released guidelines for media reporting on suicide during the pandemic that I wrote, along with support from colleagues around the world to ensure that media had the best information and best practices on reporting on suicide during a pandemic. For example, there are still suicides that take place, and yet if they're not reported on, families can feel a lot of distress that their loved one doesn't receive the normal attention that a suicide would because it's being overshadowed by the pandemic. And conversely, we also don't want to highlight suicide that doesn't call for that. And we also wanted the media to understand about reporting on numbers and research when there really was very little to add to that. So speculation and rumor around suicide numbers and deaths is another best practices that we covered. So the media has been responsive to following these best practices here in the United States and from what I've seen in different parts of the world. And that has made a difference as well in the impact that they have over people. Finally, to address the issue of what are proposed and future directions for international cooperation in suicide prevention, this is a critically important area. We definitely should look to the World Health Organization as a leader. They have identified 7 areas that have enough evidence behind to support really focusing on those areas to prevent suicide. For example, drug and alcohol policies, training programs, media coverage around suicide, restriction of lethal means. These areas should receive much additional attention by all of us around the world. If we focus our efforts on some of those and bring those up to scale, we may see improvements around reducing the burden of suicide. Since we have good evidence in these particular areas. So one area of collaboration would be around looking at the WHO recommendations, their suicide report, and the ideals that they suggest we have enough evidence for. Another area of collaboration is through the International Association for Suicide Prevention, which has a number of programs that help bring people together. For example, World Suicide Prevention Day every year on September 10th. The more we can raise awareness of this topic globally and in a connected fashion, that will help reduce stigma and will help ultimately increase people reaching out and seeking help. There are a number of other task forces, whether it's workplace task forces, the elderly, primary care physicians. All of these groups are providing continual and new evidence that if we can focus on these areas that are coming out from a global perspective through the International Association, we will have a better chance at reducing the burden of suicide. Messaging around suicide also needs to become far more universal. We need local areas to be able to adapt a universal message, but we are in the process of trying to develop some universal messaging that can help guide people so that when something is mentioned about this topic, people in the public generally understand really what the effort is and what the goals are. Not unlike breast cancer or not unlike diabetes or heart disease, we need some universal kinds of messaging that can be collaboratively taken on. There should also be strategies in every country around the world, a national strategy for each country. We need to ensure that certain policies are in place to ensure that people are getting the help that they need. And the more that more countries sign on to having national strategies and policies in place, for example, to decriminalize suicide behavior, that is going to be very positive and very helpful to bring a more unified voice and collaborative effort to suicide prevention in the world. We also should be looking at means restriction of all sorts, whether we're talking about ingestion of pesticides and how pesticides are sold and used and made accessible, to medications and how they're distributed and disseminated, and working with insurance companies or manufacturers and how those are produced and distributed, to firearms and firearm safety. All of these things, the more universal and the more collaborative we can be across the world, the more likely we are going to be to save more lives from death by suicide. Finally, we need to ensure that there is far more training for professionals that are involved in providing care and services to those that are struggling with mental health issues, chemical health issues, and suicide-related behaviors and suicidal ideation. We need far better standardized training. We need far more information about suicide prevention and research that can be done to address the issues, for example, of imminent risk around suicide, what actually prevents suicide, and move away from looking simply at risk factors as an assessment of who might be at risk of dying by suicide. The more collaborative we can be across the world around looking at the research, looking at how these our research questions are interpreted and aligned with training programs for people in their graduate studies and in their professional studies and in the ongoing continuing education, the better off we're going to be. If we don't have providers that know how to help and how to ask the right questions about suicide and how to provide services, and we don't provide access to those services, we are never going to be able to reduce the burden of suicide. So the more collaborative we can be on all of these issues, the more policies and practices that can be put in place, the more lives we're going to save. I want to thank you for allowing me to be a part of this conference and this messaging and have the opportunity to share some of the things that are taking place in the United States as we address COVID and address the broader issues of suicide prevention. Thank you.